Welcome in, whether you're a medical student cramming for your boards or maybe a junior doctor navigating the wards at 3 a.m.
Or a public health trainee trying to make sense of the massive systems shaping our world.
Exactly. We are thrilled to have you here. Today we are embarking on a conceptual deep dive into the absolute foundations of population health.
The bedrock.
Right. And to kick things off, I want you to just imagine something with me. Imagine that clinical medicine, so the day-to-day work of seeing patients in a clinic, diagnosing an illness, prescribing a treatment, imagine that is like being a highly skilled plumber.
Okay, I like this, a plumber.
Yeah, so you're called to a specific house because the sink is overflowing, the water is ruining the floorboards, the homeowner is completely panicking, and you use your incredible specialized tools to stop the leak. You patch the pipe, and you essentially save the day.
Which is vital work. It's undeniably life-saving work.
It is, but public health. Public health is not the plumber. Public health is the civil engineer working 50 miles upstream.
Right.
Public health is the team analyzing the watershed, designing the city's reservoir, building the massive water filtration systems, and laying out the entire underground pipe network.
To ensure that no house in the city ever slids in the first place.
Exactly. And that is precisely the shift in perspective we're making today.
It is. Our mission for this deep dive is to systematically unpack the foundational frameworks laid out in Chapter 1.1 of the Oxford Textbook of Global Public Health. Specifically, the section authored by Roger Dadles and Chor-Chuan Tan on the scope and concerns of the field.
And we should clarify, we aren't here to simply list definitions for you to memorize.
No, absolutely not. Memorization doesn't help you on the wards, and it certainly doesn't help you design health policy. Our goal is to build clear, robust, conceptual architecture. We want to trace the pathway from a localized environmental risk,
Like a chemical spill.
right, to a population-level exposure, to a measurable health outcome, and finally to a systemic intervention. We highly encourage you to read the chapter alongside this discussion.
Use our conversation to strengthen your reasoning, challenge your assumptions, and really start to recognize the underlying patterns of disease and prevention.
We're looking for the matrix beneath the data.
We really are. So let's start at the very bedrock, the core definition. The widely accepted standard comes from the Atchison Report, which defines public health as the science and art of preventing disease, prolonging life, and promoting health through the organized efforts of society.
And what stands out immediately there is that duality, right?
Well,
Science and art.
Yes, it requires the rigorous quantitative science of epidemiology and biostatistics.
That hard data.
Right, but also the nuanced, deeply sociological art of persuasion, policymaking, and community engagement. And crucially, it relies on the organized efforts of society. It takes the burden of health off the isolated individual and places it squarely on the collective structure.
Which, if we connect this to the broader evolution of the field, that definition represents a monumental paradigm shift. I mean, in clinical medicine, the locus of control and intervention is the individual encounter. You have a patient, a pathology, and a treatment plan.
The plumber fixing the pipe.
Exactly. Public health completely zooms out. You are no longer treating the person sitting on the exam table, you're treating the entire demographic cohort. And Attell's expanded on this objective significantly in 2003.
Oh, this is the expansion about well-being. Right?
Yeah, he argued that the ultimate goal of public health isn't just the absence of disease, but the biologic, physical, and mental well-being of all members of society. And explicitly regardless of gender, wealth, ethnicity, sexual orientation, country, or political views.
That expansion feels so critical because it bakes equity directly into the operational definition of the field. It's not an afterthought, it's the primary directive.
That's the whole point.
And explicitly including mental well-being is a massive correction to decades of policy that treated mental health as somehow separate from, or, secondary to physical health.
Yes.
It shifts the entire mission from a defensive posture of just fighting disease to a proactive posture of engineering the optimal conditions for human flourishing.
Precisely. It sets an incredibly high bar. But setting the goal is one thing, right?
Yeah.
Operationalizing it is another. How does a society actually organize its efforts to achieve that?
Yeah.
That is where we turn to the 14 core functions of public health.
Now, for you listening, do not view this as a static checklist to memorize for a multiple choice exam. Think of these 14 functions as the operating system of a functioning society.
I love that framing, an operating system.
Okay, let's unpack this operating system. The very first function is identifying, measuring, and monitoring health needs. We often call this surveillance.
Right. And we need to differentiate here. In a clinical setting, screening means checking one patient's blood pressure to prevent a stroke. But population surveillance is an entirely different beast. It's syndromic and indicator-based.
Think of surveillance as society's early warning radar.
Exactly. It is the continuous, systematic collection, analysis, and interpretation of health-related data. You are looking for anomalies in the baseline.
Like tracking over-the-counter med sales.
Yes, this could be monitoring the purchasing trends of antidiarrheal medications to catch a waterborne outbreak before the local hospitals fill up. Or it could be tracking a subtle rise in vaping among middle schoolers.
Or, most critically, noticing a sudden, unexplained cluster of atypical pneumonia in a specific geographic area.
Which is exactly how outbreaks like SARS or COVID-19 are initially detected. Without a highly sensitive, well-funded radar system, you are flying blind. You cannot allocate resources or anticipate future crises without that foundational data infrastructure.
Right. And once that radar picks up a signal, the system has to respond. That transitions us into the functions of policy development and assurance. And this is where the art of public health really collides with the science.
Because having the data is useless if you can't translate it into actionable policy.
Policy development is the mechanism by which public health exercises its structural power. If the data shows that a specific chemical runoff is causing neurodevelopmental delays in children,
public health must formulate, promote, and enforce environmental regulations to stop that runoff.
Exactly. It means enacting laws requiring clinical laboratories to immediately report highly transmissible pathogens to central authorities.
But creating a law is only the first step. The complementary function is assurance. Assurance means guaranteeing that the systems, services, and workforce required by that policy actually exist and are accessible.
So if I'm understanding the distinction here, policy development is mandating that every child receives a measles vaccine before entering the school system. And assurance is ensuring that the local clinics actually have cold chain storage for the vaccines, that the nurses are trained to administer them, and that the vaccines are free or affordable for every single family in that district. If you have the policy without the assurance, you just have an unfunded mandate.
That is an excellent summary. And that concept of assurance leads directly into one of the most vital and often most politically charged functions on the list. Reducing health disparities and ensuring access for all.
Which brings up a fascinating angle to explore. We've established the moral and ethical imperative for equity, but there's also a cold, pragmatic, biological reality at play here. Why should the most insulated, healthiest, or wealthiest members of a society care deeply about the health of its most marginalized and vulnerable groups? Beyond basic human empathy, what is the systemic argument?
The systemic argument is that biology does not respect socioeconomic boundaries, or gated communities for that matter.
Pathogens are opportunists.
They absolutely are. Communicable diseases frequently find a reservoir in vulnerable populations, maybe due to overcrowded housing, poor sanitation, nutritional deficits, or just a sheer lack of access to primary care. If an infectious disease is allowed to incubate and spread rapidly within a marginalized community, the sheer mathematical probability of it spilling over into the broader population increases exponentially.
Wow. So ignoring the vulnerable is not just an ethical failure, it is a profound biosecurity vulnerability for the entire society.
Exactly. Furthermore, on an economic level, health inequalities artificially cap the functional capacity of millions of people. A society carrying a massive burden of untreated chronic illness or preventable disability is a society operating at a fraction of its potential economic and social output.
It's the ultimate systemic interconnectedness. And looking at the evolution of these core functions, it's clear the field is adapting to modern realities. The inclusion of disaster preparedness, and not just for natural events like earthquakes or typhoons, but man-made disasters and bioterrorism, shows how the scope has widened. Even more striking is the explicit inclusion of reducing the impact of interpersonal violence and aggressive war.
That specific inclusion represents a massive conceptual leap. Historically, interpersonal violence, gang conflict, or domestic abuse were siloed entirely within the criminal justice system.
Right. Treated purely as a crime issue.
Exactly. But when you look at the epidemiological data, in certain demographics, particularly among adolescent and young adult males in specific urban centers, violence is the leading cause of premature mortality. When a phenomenon systematically ends thousands of lives and devastates community structures, it is a public health crisis. It requires epidemiological mapping, root cause analysis, and preventive interventions, not just punitive policing.
And to figure out those interventions, we have the final crucial modern addition to the framework, implementation science. This addresses a massive frustration in medicine.
Oh, it really does.
We can discover a miraculous cure or a brilliant preventive strategy in a highly controlled academic laboratory. But implementation science is the rigorous study of the translational gap. It's the science of figuring out why a proven intervention fails when it hits the messy, complex reality of human behavior and underfunded clinics, and how to redesign the delivery so it actually reaches the population.
It's the bridge between theoretical efficacy and real-world effectiveness. It acknowledges that knowing what to do is only 20% of the battle. Knowing how to get diverse populations and complex health systems to actually do it is the other 80%.
So we have this robust operating system, these 14 functions designed to protect the population, but how do we measure if any of this is actually working? How do we measure the architecture of disease?
That's the big question.
For decades, the default metric has been mortality, death rates. And as an audience of medical professionals, you are all deeply familiar with mortality data. It's binary, it's easily tracked on death certificates, and preventing death is obviously a high priority. But when we look at population health, mortality data has some devastating blind spots.
It really does. Relying solely on mortality rates creates a profoundly skewed picture of societal health. Mortality tells you who died, but it renders the suffering of the living entirely invisible.
It's a binary that ignores quality of life.
Exactly. If we only measure health by what kills us, we systematically deprioritize conditions that severely compromise human function but are non-fatal. We end up ignoring the massive, crushing societal burden of osteoarthritis, chronic back pain, major depressive disorders, blindness, and non-fatal traumatic injuries.
A health system optimized solely to prevent death is not the same as a health system optimized to promote life.
We require much more sophisticated, nuanced metrics.
Which brings us to the evolution of morbidity metrics, starting with YPLL, years of productive life lost. How does YPLL change our perspective compared to a raw mortality rate?
Well, YPLL introduces the concept of time into the equation. It shifts the focus from the sheer volume of deaths to the age at which those deaths occur. In traditional YPLR models, a benchmark of a productive lifespan is set often arbitrarily around 65 or 75 years, depending on the specific model.
Okay.
The calculation is simple but profound. If an individual dies of pneumonia at age 80, that is a personal tragedy, but it contributes 0 to the YPLL metric because they surpassed the 75-year benchmark. However, if a 20-year-old dies in a motorcycle crash or from an overdose, that single death contributes 55 years of productive life lost to the metric.
So if I'm looking at a public health budget, using YPLL completely rewires my funding priorities. Suddenly, diseases that primarily affect the elderly drop down the priority list, and interventions targeting youth like violence prevention, traffic safety, or pediatric oncology shoot to the top because those interventions save decades of life per individual, not just a few years.
It's a pragmatic, albeit somewhat ruthless way to maximize human potential.
It really is.
And it has successfully driven massive public health campaigns regarding seatbelts and childhood immunizations. But YPLL still fundamentally relies on death. It doesn't capture the burden of living with a severe disability.
Here's where it gets really interesting. That is where we get to the gold standard of modern public health metrics. DALYs, or disability-adjusted life years. This metric was a revolution when it was introduced by the Global Burden of Disease study. How exactly do DALYs differentiate from YPLL?
DALYs are a masterclass in health economics. They combine the concept of premature mortality with the burden of compromised function. The formula essentially states that 1 daily equals 1 lost year of healthy life. It is the sum of years of life lost due to premature mortality, that's YLL, plus the years lived with disability, or YLD. The goal is to measure the gap between the current health status of a population and an ideal scenario where everyone lives into old age entirely free of disease and disability.
But wait, how do we objectively measure a disability? Who decides that a year living with severe asthma is worth, say, 0.4 of a daily, while a year with blindness is worth 0.6?
Isn't quantifying human suffering inherently subjective?
You have hit on the most controversial and complex aspect of the daily framework. The methodology of assigning disability weights is highly rigorous, but still heavily debated.
I can imagine.
Researchers use massive global surveys asking health professionals and the general public to weigh different health states against each other. They're essentially asking, how much functional loss does this condition represent compared to perfect health or death? It is an imperfect science, but it is a necessary abstraction. because without quantifying that disability, it remains invisible to policymakers holding the purse strings.
And when those policymakers finally look at the data through the daily lens, the shift in global priorities is staggering. What happens to the map of human disease when we use dailies? The landscape transforms completely. Conditions that have low mortality but high chronic morbidity suddenly dominate the charts. We see the true devastating impact of neglected tropical diseases and chronic respiratory conditions. But the most profound revelation of the daily metric was the explosive rise of neuropsychiatric disorders.
Right, mental health.
Yes. When you combine the early onset of conditions like schizophrenia, major depressive disorder, and bipolar disorder with their lifelong severe functional impairment, they generate massive daily counts. They account for a huge percentage of the global burden of disease, fundamentally forcing global health organizations to acknowledge that mental health is a primary, not secondary, driver of human suffering.
That is a total paradigm shift in resource allocation. And speaking of massive historical shifts, let's transition to the epidemiological transition. If we look at the timeline from 1900 to the year 2000, we see a complete inversion of what kills human beings.
A total flip.
In 1900, the leading causes of death in developed nations were communicable: pneumonia, tuberculosis, influenza, diarrheal diseases. By 2000, the leading causes are non-communicable: ischemic heart disease, cancers, cerebrovascular disease. The popular narrative is that brilliant doctors invented antibiotics and vaccines, and that's how we conquered infectious disease. But the historical data tells a much more structural story.
The heroic narrative of medicine often overshadows the quiet triumphs of civil engineering.
The upstream engineers again.
Exactly. While vaccines and antibiotics were miraculous and crucial, particularly in the mid to late 20th century, the steepest declines in infectious disease mortality actually occurred long before these medical interventions were widely available. The true heroes of the early epidemiological transition were the sanitation boards, the urban planners, and the labor reform movements.
So what specific interventions actually drove that massive decline in tuberculosis and cholera?
It was a fundamental redesign of the human ecosystem. It was the construction of massive sewer systems that physically separated human waste from drinking water, practically eliminating waterborne scourges like cholera and typhoid. It was housing reforms that reduced the severe overcrowding in urban tenements, which drastically cut the airborne transmission of tuberculosis.
Just giving people space to breathe.
Precisely. It was also the implementation of child labor laws and improved agricultural supply chains, leading to better baseline nutrition, which strengthened the innate immune responses of the entire population. We didn't just kill the pathogens, we engineered an environment where they could no longer thrive.
That success was so profound that it actually bred a dangerous level of overconfidence. By the late 1970s and early 1980s, after the triumphant global eradication of smallpox, many leading public health figures honestly thought the war against infectious disease was essentially won. They believed it was a solved problem.
It was a moment of profound scientific hubris. We projected a linear trajectory of success and fundamentally underestimated the relentless adaptability of biology. We assumed that our arsenal of antimicrobials and vaccines had permanently tipped the evolutionary scale in our favor.
And then the 1980s arrived, and that assumption was violently shattered by the emergence of HIV/AIDS.
Exactly. HIV/AIDS demonstrated how a novel, insidious retrovirus could silently exploit the very networks of global connectivity and shifting social norms that define the modern era. And just as the world began to manage HIV through massive pharmaceutical and behavioral interventions, the early 2000s brought the SARS coronavirus outbreak.
Another stark reminder.
Nature issued a stark reminder. As long as humans continuously encroach on animal habitats, industrialize agriculture, and travel globally, new zoonotic pathogens will emerge and old pathogens will mutate. The era of infectious disease is never over. It simply evolves.
And while the developed world was grappling with this realization, a much more complex crisis was unfolding in low- and middle-income countries, or LMICs. The data points to a very clear, vicious cycle connecting poverty directly to disease. With over a fifth of the population in some developing regions living on less than $1.25 a day, these nations are facing what is termed the double burden of disease.
The double burden is arguably the defining global health architectural challenge of our time. Historically, we had a need divide. Poor countries suffered from communicable infectious diseases, and wealthy countries suffered from the non-communicable diseases of affluence and aging. But globalization disrupted that binary.
Right, because globalization didn't just export technology and capital, it rapidly exported the behavioral risk factors of the West.
Precisely. multinational corporations aggressively expanded into LMICs, bringing highly processed, calorically dense, but nutritionally poor diets. The tobacco industry, facing strict regulations in the West, pivoted aggressively to market to populations in the developing world. Rapid, unplanned urbanization led to massive decreases in daily physical activity as people transitioned from agrarian labor to sedentary factory or informal gig work.
So the result is this catastrophic perfect storm. These nations have not yet built the sanitation infrastructure or healthcare capacity to conquer the old communicable threats. Malaria, tuberculosis, cholera still rage in many areas, accounting for roughly 30% of the global disease burden. But simultaneously, their populations are experiencing explosive epidemics of type 2 diabetes, hypertension, and cardiovascular disease. They're fighting a two-front war on a fraction of the budget.
And this two-front war is being radically accelerated by unprecedented demographic shifts. We are experiencing a global phenomenon often referred to as the silver tsunami. The numbers are staggering. In the year 2000, roughly 8% of the global population was over the age of 65. Demographic projections suggest that by 2050, that figure could jump to nearly 30% in many regions.
Think about the systemic shock of that. When a third of your entire population is over 65, what happens to the underlying structure of a society?
The macroeconomic and healthcare implications are severe. We are looking at a future with an inverted demographic pyramid. You have a shrinking base of young, economically productive workers generating tax revenue, supporting a massively expanding apex of elderly dependents who require highly complex, chronic healthcare and pension support.
It flips the whole model upside down.
Yeah, it does. The dependency ratio becomes economically unsustainable. This demographic reality necessitates a complete rethinking of public health. We can no longer just focus on extending the absolute lifespan. We urgently need to focus on health span compressing morbidity so that individuals remain highly functional, independent, and perhaps economically active much deeper into their chronological age.
But keeping people functional requires protecting them from the threats of a hyper-connected world, which brings us to communicable diseases in the modern era. When you look at the map of emerging infectious diseases from the last few decades, H5N1, avian influenza, Nipah virus, Ebola outbreaks, Zika, it feels like these novel threats are accelerating. Why are they emerging so rapidly?
What's fascinating here is that it is entirely driven by human activity altering the biosphere. We are systematically dismantling the ecological barriers that previously separated human populations from deep forest wildlife reservoirs. The vast majority of these emerging threats are zoonotic, meaning they originate in animals and make an evolutionary leap into humans.
Let's break down the mechanisms of that zoonotic leap. How exactly are we facilitating this?
The mechanisms are multifaceted. First, we have massive demographic changes in deforestation. As human populations expand, we push logging, mining, and agriculture deep into previously isolated ecosystems, exposing workers to novel vectors. Second, we have modern, hyperdense agricultural practices. When you pack tens of thousands of genetically similar poultry or swine into tight confinement, you create the ultimate mixing vessel for viral reassortment.
Right.
Third, you have the interface of wet markets in various parts of the world, where highly diverse, stressed, live animal species from different ecosystems are caged directly alongside human populations. Finally, climate change is actively altering the geographical ranges of insect vectors. Mosquitoes carrying dengue or malaria can now survive at higher altitudes and latitudes that were previously too cold for them.
We are essentially building the perfect obstacle course for pathogens to evolve, and then once they do leap into a human, we give them a first-class ticket around the world.
We do.
The speed of our global transport networks is literally the speed of our transmission networks. An individual infected with a novel respiratory virus in a rural village can travel to a regional hub, board an international flight, and land in a megacity on another continent before they even develop a fever.
Exactly. Quarantine, the oldest tool in public health, relied on the fact that travel used to take longer than the incubation period of most diseases. If you caught cholera on a ship, you showed symptoms before you reached the port. Air travel has completely subverted that biological safety net.
And it's not just the novel viruses we have to worry about. It's the terrifying evolution of the bacteria we thought we had already defeated. Antimicrobial resistance, or AMR, is arguably the most predictable slow-motion disaster in modern medicine. The text highlights a specific chilling example, NDM1, or New Delhi metallobeta-lactamase. Let's dive into the biology of this.
NDM1 is a perfect illustration of an evolutionary arms race that we are actively losing. It is an enzyme that renders bacteria highly resistant to a broad range of beta-lactam antibiotics, which are often our last lines of defense.
So how did we create this monster?
Through the ubiquitous, often reckless overuse of antibiotics in both human medicine and, crucially, in industrial agriculture. When you constantly bathe bacterial populations in sublethal doses of antibiotics, you apply massive selective pressure. Only the mutated, resistant strains survive to replicate.
And here is where the biology gets truly insidious. If I understand the mechanism correctly, bacteria don't just pass this resistance down vertically to their offspring. They can share it horizontally. It's like they have an open source code for survival.
That is a brilliant analogy. The genes encoding for resistance, like NDM1, are often located on plasmids, small, circular, mobile pieces of DNA. Bacteria can literally transfer these plasmids laterally, even to completely different species of bacteria, right there in the human gut or in a hospital wastewater system. A harmless commensal bacterium can download the resistance code from a dangerous pathogen.
That's terrifying.
We are facing the genuinely terrifying prospect of a post-antibiotic era where routine surgeries, chemotherapy, and minor injuries once again become potentially lethal because the drugs simply no longer work.
While we brace for the superbugs of the future, we also have to confront the systemic failures of the present. Specifically, the diseases we already know how to cure but simply choose not to. Let's talk about neglected tropical diseases, or NTDs. We are talking about conditions like lymphatic filariasis, trachoma, and schistosomiasis. Over 1 billion people, 1/6 of the global population, suffer from these.
The operative word here is neglected. These pathogens primarily afflict the absolute poorest, most marginalized populations on Earth, people living in remote rural communities, urban slums, or conflict zones without safe water or adequate sanitation. Because these diseases rarely spark explosive, terrifying pandemics that threaten the wealthy capitals of the global North, they receive a fraction of the research funding, pharmaceutical development, and media attention of diseases like COVID-19 or Ebola.
It's a massive global market failure, and the systemic impact is devastating. These diseases may not always kill rapidly, but they cause severe, lifelong disfigurement, chronic pain, and profound functional compromise. Blindness from trachoma or severe limb swelling from lymphatic filariasis entirely destroys an individual's ability to work or care for their family.
They act as an anchor.
Yes, trapping entire generations and severely compromising the macroeconomic competitiveness of the nations burdened by them. Curing NTDs isn't just a medical intervention, it is a profound macroeconomic stimulus and an act of basic global equity.
Which is a perfect segue into other areas of massive global neglect. We need to shine a light on what the field often terms the silent epidemics. These are conditions that exact a staggering toll on dailies, but historically receive very little political capital or structural funding.
Let's start with the most glaring one, mental illness. The data indicates that mental and substance use disorders account for roughly 13% of the total global burden of disease. 13%. Yet the structural funding is virtually non-existent in many parts of the world.
The systemic failure in resource allocation for mental health is profound. In many low- and middle-income countries, the budget allocated for mental health averages out to merely 25 cents per patient per year. You often find ratios of less than one psychiatrist for every 200,000 people.
Wow.
Consequently, between 76% and 85% of individuals suffering from severe mental disorders in these regions receive absolutely no evidence-based treatment. We are squandering millions of years of human potential. Mental illness, much like an NTD, robs society of productive life, yet it remains shrouded in cultural stigma and structurally ignored by health ministries. As our populations age and the dependency ratios shift, leaving this massive demographic without care is a societal failure we literally cannot afford.
Another silent epidemic that forces us to look at structural failures rather than just biological ones is injuries. When we hear the word accident, we think of a random, unavoidable act of fate. But the epidemiological data tells a different story. In 2011, there were roughly 5.8 million deaths globally from injuries. This includes interpersonal violence, self-directed violence, and crucially, road traffic incidents.
This is where the public health lens of pattern recognition is essential. If you view a car crash purely as an isolated tragedy, you miss the systemic failure. Injuries are not random. They follow distinct epidemiological patterns. Because they are highly predictable, they are eminently preventable.
Let's look at the mechanisms of that prevention. The text notes that mortality rates from traffic accidents are nearly 3 times higher in developing nations than in high-income nations. Why? It's not because people in developing nations are worse drivers, it's a structural deficit.
Exactly. It is a failure of the built environment. It is a lack of improved paved roads. It is a lack of physical barriers separating high-speed vehicular traffic from pedestrians and cyclists. It is the failure of governance to enact and strictly enforce structural safety interventions. When countries like Indonesia or Vietnam instituted and rigorously enforced mandatory motorcycle helmet laws, they saw an immediate drastic plummet in traumatic brain injuries and fatalities.
Proving that you don't need a medical breakthrough to save thousands of lives.
You just need a structural intervention and the political will to enforce it.
Okay, let's unpack one more silent epidemic that frequently flies under the radar of traditional medicine: oral health. We tend to silo dentistry away from primary care, treating it almost as a cosmetic luxury. But the global metric is startling. Roughly 30% of adults aged 65 to 74 worldwide are completely edentulous, meaning they have lost all of their natural teeth.
This statistic forces us to interrogate how we define holistic health. Treating oral care as an expendable add-on is a profound clinical and public health error. The mouth is the gateway to the body. If an individual has no teeth, their nutritional intake is severely compromised, accelerating frailty and cognitive decline in old age. Poor dentition and chronic periodontal disease are strongly linked to systemic inflammation, exacerbating diabetes and increasing the risk of cardiovascular events like endocarditis.
And oral cancers as well.
Yes, poor oral hygiene, especially when combined with cultural risk factors like tobacco use or betel nut chewing in parts of Asia, directly drives the incidence of oral cancers, which rank among the most common cancers globally. Oral health is deeply tied to social capital, employment opportunities, and systemic well-being. It is a core pillar of public health.
And all of these outcomes, from mental health to traffic injuries to oral cancers, are deeply influenced by the environment we navigate daily. Which brings us to the macro level: environmental and occupational exposures. We are living in an era of unprecedented chemical synthesis. There are over 14 million known chemicals, and we actively use over 60,000 of them in our daily lives. They are woven into our agriculture, our construction materials, our electronics, and eventually they leach into our groundwater and air. We are conducting a massive, uncontrolled toxicological experiment on the human population.
And the defining characteristic of this chemical landscape is that it completely ignores national sovereignty. Environmental health is inherently transboundary.
Right, the text uses a very visceral example of this. The seasonal slash and burn agricultural practices in Indonesia don't just affect local farmers. The massive plumes of smoke and particulate matter drift across the ocean, creating severe, suffocating haze events and spiking respiratory hospitalizations in neighboring sovereign nations like Singapore and Malaysia.
Exactly.
Or consider the industrial history of the United States. Sulfur dioxide emissions from coal plants in the American Midwest drifted north, falling as acid rain that devastated the aquatic ecosystems of Canadian lakes. You simply cannot protect your population's health solely within your own borders.
And this transboundary effect reaches its ultimate planetary scale with climate change. The World Health Organization estimates that the shifts in climate may have already contributed to 150,000 additional deaths annually since the mid-1970s.
That's a staggering number.
And this isn't just about heat stroke. It is about the changing geography of infectious vectors. It is about prolonged droughts, decimating crop yields, leading to population-level malnutrition, which subsequently crashes immune systems and paves the way for diarrheal diseases to ravage vulnerable pediatric populations.
While the macroclimate shifts above us, we are also engineering novel microscopic hazards. The text specifically highlights the emerging threat of nanoparticles. We are manufacturing these materials at an atomic scale, a billionth of a meter, and putting them into our cosmetics, our food packaging, and our pharmaceuticals.
The biological mechanism of nanoparticles is what makes them a unique toxicological puzzle. Because they are so unfathomably small, they do not behave like larger particles of the exact same chemical composition. Their tiny size allows them to easily bypass traditional biological barriers, like the blood-brain barrier or the alveolar membranes in the lungs.
Once inside, what do?
Once inside the cells, they can become highly reactive, generating reactive oxygen species. Recent literature indicates they can cause significant oxidative stress and damage to lung tissue, hepatic cells, and neuronal networks. It is a classic regulatory dilemma. Industrial innovation massively outpaces our epidemiological understanding, and we introduce these materials into the consumer ecosystem decades before we fully comprehend their long-term pathogenesis.
And where are adults most consistently exposed to these chemical and physical hazards? The workplace. The text dedicates significant focus to occupational health, pointing out that there are roughly 2.3 million work-related deaths annually. To put that in perspective, that exceeds the global mortality from either heart attacks or strokes. And the very nature of work is undergoing a massive structural shift.
If we trace the systemic patterns, the global supply chain has fundamentally altered occupational vulnerability. Heavy manufacturing and high-risk production have largely been outsourced from developed nations where labor unions and occupational safety regulations are robust to low- and middle-income countries where oversight is often minimal and labor is cheap.
Furthermore, we are seeing a massive global transition away from formal contracted employment toward the informal economy and gig work.
Exactly. Informal workers now represent over 50% of the global workforce. These individuals operate entirely outside the protective net of occupational health. They lack employer-sponsored health insurance, they lack paid sick leave, they lack workers' compensation, and they lack the legal right to unionize for safer conditions. When an informal construction worker or a gig economy delivery driver is injured on the job, they don't simply lose a few days of wages. They frequently plunge their entire family into catastrophic financial ruin. Modernizing public health means recognizing that labor rights and robust social safety nets are foundational health interventions.
So, we have mapped out a terrifyingly complex matrix of threats. We've gone from the microscopic transmission of antibiotic-resistant plasmids to the macroeconomic shifts of the gig economy, from the silent suffering of depression to the planetary shifts of climate change. The ultimate question is, how do we actually intervene? How does public health fight back? The text outlines a framework of 4 primary pillars of intervention. Let's walk through the mechanics of each. First, we have social, biological, and environmental interventions.
This first pillar is often the most cost-effective because it alters the biological or physical landscape directly. The quintessential biological intervention is mass immunization. It leverages the mechanics of herd immunity, requiring very little daily behavioral change from the individual. You simply receive the vaccine, and the population barrier is strengthened. The structural social intervention highlighted in the text is DOTS, directly observed treatment, short course for tuberculosis.
I love the DOTS example because it beautifully merges biology and sociology. You have a biological cure, the antibiotic regimen, but TB requires months of strict adherence. If a patient stops taking the pills when they feel better, the bacteria mutate, and you generate multi-drug resistant TB. So the DOTS strategy essentially engineers compliance. Health workers literally sit with the patient and observe them swallowing every single dose. It's a socially structured biological intervention. And then, of course, the ultimate environmental intervention is the civil engineering we discussed earlier, building the water filtration plant so the cholera bacterium simply cannot reach the human host.
The second pillar, however, is significantly more complex: behavioral interventions.
This is famously the hardest one. You are trying to convince human beings to change their daily habits, to quit smoking, to change their diet, to practice safe sex. Humans are notoriously resistant to top-down medical lecturing, but the text introduces a fascinating sociological strategy: the popular opinion leader model.
Modifying population behavior requires understanding network theory and the diffusion of innovations. If a government official or a physician simply lectures a community, the message often hits a wall of cultural resistance or mistrust. The popular opinion leader model bypasses that. Epidemiologists and sociologists map the social network of a target community to identify the organic, trusted nodes, the trendsetters, the matriarchs, the highly respected peers, the local barbers. These individuals are trained and empowered to adopt and naturally promote healthy behaviors within their own circles.
So the message comes from inside the house, so to speak.
Exactly. The community shifts its norms, not because an authority figure mandated it, but because the people they admire modeled it. It's leveraging organic social clout for public health. This model was utilized with incredible success in the United States during the peak of the HIV epidemic to rapidly normalize condom use and safe sex practices within the LGBTQ+ community.
It is a brilliant use of sociology. But behavioral nudges aren't always enough, which brings us to the third pillar: political interventions. The text states it bluntly: public health is politics. You cannot decouple the two.
It is an unavoidable reality. To achieve massive population-level protection, you inevitably have to confront entrenched economic interests, and that requires navigating the political arena. Consider the multi-decade war against tobacco. Public health researchers proved the carcinogenic mechanics of smoking in the mid-20th century. But knowing the science did nothing to stop the epidemic because they were up against the staggering lobbying power, marketing budgets, and legal frameworks of the multinational tobacco industry.
Right. Winning that fight didn't happen in a laboratory. It happened in legislatures and courtrooms. It required massive political mobilization to pass exorbitant excise taxes on cigarettes, to legally ban smoking in indoor public spaces, and to mandate graphic warning labels on packaging. Addressing transboundary issues like climate change or particulate air pollution requires negotiating incredibly complex international treaties. If you are entering the field of public health, you must be prepared to be a political advocate. You must learn how to draft policy briefs, testify before committees, and build coalitions.
Which logically culminates in the fourth pillar, structural interventions. This is the ultimate output of successful political lobbying. Structural interventions alter the physical or legal environment so that the safest choice becomes the default choice. We don't just rely on an educational campaign telling people to drive carefully. We pass a law mandating that all automotive manufacturers install three-point seatbelts and airbags in every vehicle. We engineer the roads with rumble strips and lower speed limits. We structurally force the environment to protect the human body.
But orchestrating all of these interventions, whether it's passing a tax, mandating a vaccine, or altering behavior, requires managing public psychology. The text introduces a highly nuanced concept here, the anxiety balance.
This is perhaps the most delicate art in the practice of public health leadership. To provoke a complacent society into action, to convince them to fund a massive infrastructure project or adhere to a quarantine or accept a new regulation, you must elevate their perception of risk. You must raise their collective anxiety about a threat until they care enough to act.
I picture it like a soundboard in a recording studio. You have to push the fear and urgency fader up high enough so the audience actually hears the music and gets out of their seats. But if you push that fader too high, the audio clips, it distorts and it blows the speakers out.
That is an excellent metaphor. If the anxiety is pushed too high, the system distorts. It leads to mass panic, which quickly devolves into fatalism. The public decides the threat is overwhelming, so they simply give up and ignore the guidelines entirely. Or, far more destructively, excessive fear breeds stigmatization and scapegoating. We witnessed the tragic consequences of this in the early years of the HIV/AIDS epidemic. Fear-mongering narratives pushed the anxiety too high, resulting in the cruel societal isolation, discrimination, and marginalization of infected individuals, which ultimately drove the epidemic underground and made it harder to treat. The masterstroke of a public health leader is finding the precise resonant frequency of anxiety that motivates constructive, unified action without fracturing social cohesion.
It is a phenomenal tightrope walk. And it is further complicated by the inherent, sometimes brutal, ethical tensions embedded in the field. In clinical medicine, the ethical mandate is relatively straightforward. Your primary fiduciary duty is to the autonomy and well-being of the patient sitting in front of you. But in public health, your patient is the population. And occasionally, the rights of the individual and the safety of the population violently collide.
The text highlights classic case studies to map the contours of this ethical friction. The most historically famous is the case of Mary Mallon, known as Typhoid Mary. She was a healthy, asymptomatic carrier of the Salmonella typhi bacterium who worked as a cook in early 20th century New York. Because she refused to stop cooking, she initiated multiple deadly outbreaks. The state's public health authorities ultimately tracked her down and forcibly incarcerated her in isolation on an island for decades until her death. Was this a profound violation of her individual liberty, bodily autonomy, and human rights? Undeniably, yes. Was it deemed necessary by the state to protect the collective population from a lethal pathogen? Also, yes.
And the text brings this tension into the modern era with a very common clinical dilemma. Imagine a man who engages in high-risk behaviors but vehemently refuses to be tested for HIV, citing his fundamental right to privacy and bodily autonomy. If you strictly protect his individual right not to know, you potentially violate the right of his intimate partners to be protected from a lethal transmissible infection. How do you balance the scale?
The uncomfortable truth is that public health is rarely about finding a perfect, consequence-free solution. It is a constant calibration. It is a daily negotiation between maximizing collective utility and minimizing the infringement on individual liberty. There are rarely easy answers, only difficult, legally fraught balances that must be continually reassessed as society evolves.
That is heavy, but it is exactly why we need these clear conceptual frameworks to guide our reasoning. So let's summarize this incredible, wide-ranging journey we've been on. We began by fundamentally shifting our lens, moving away from the micro-reactive view of the clinical plumber fixing a single leak to the macro, proactive view of the civil engineer designing the resilient infrastructure of a city. We established that the mission isn't merely preventing death, but actively promoting equitable, functional life across populations, which is why transitioning to morbidity metrics like day lives completely revolutionizes our funding priorities. We trace the massive arc of the epidemiological transition, realizing that while civil engineering conquered the cholera of the 1900s, modern globalization, poverty, and shifting demographics have cursed the developing world with a catastrophic double burden of both ancient infections and modern chronic diseases.
And we map the biological mechanisms of zoonotic spillover and the terrifying lateral gene transfer driving antimicrobial resistance. We shone a much-needed light on the structurally ignored silent epidemics, the daily crushing impact of mental illness, the preventable structural failures causing traffic injuries, and the systemic ripple effects of poor oral health. We explored how environmental hazards, from transboundary smog to microscopic nanoparticles, require global, not local, governance.
And finally, we unpack the complex art of intervention, how we utilize sociology, navigate the bruising arenas of politics, tune the societal anxiety dial, and wrestle with the profound ethical burden of balancing the liberty of the one against the survival of the many. It is a massive, awe-inspiring scope. But mastering this architecture is the foundation of everything you will do in this field.
It is indeed. And to ensure that these expansive frameworks solidify in your memory long after this audio concludes, let's transition into our learning reinforcement segment. I am going to deliver 5 rapid, single best answer style recall prompts based on the core concepts we just discussed. I will pause briefly after each question. I strongly encourage you to actively retrieve the answer in your mind before I provide the solution. Let's begin. Prompt 1. Which epidemiological metric is most appropriate for highlighting the profound global burden of non-fatal but highly disabling conditions, such as major depressive disorder or schizophrenia? Take a second to think about that. Right, the answer is disability-adjusted life years, or DALYs. If you need to consolidate the methodology behind this metric, review the Measuring Disease Occurrence section of the chapter. Prompt 2. What is the primary underlying structural driver for the rapid, catastrophic increase in non-communicable diseases, or NCDs, like type 2 diabetes and cardiovascular disease in low- and middle-income countries? Got it. Answer. Social and behavioral risk factor shifts driven by rapid globalization and unplanned urbanization, specifically the introduction of highly processed diets, aggressive tobacco marketing, and decreased physical activity. Review the non-communicable diseases section. Let's move to prompt 3. A government passes legislation requiring the installation of 3-point seatbelts and automatic braking systems in all new vehicles. This falls under which the 4 primary categories of public health intervention? Have your answer. Answer. A structural intervention, as it alters the physical environment to make the safe choice the default choice. Review the public health intervention section.
2 more left.
Prompt 4. What fundamental ethical tension in public health is most vividly illustrated by the historical incarceration of Mary Mallon, or Typhoid Mary? Think on it. Answer. The inherent conflict between protecting individual civil liberties and bodily autonomy versus the state's mandate to protect collective population safety from a transmissible threat. Review the Ethics in Public Health section. Finally, prompt 5. According to the core functions of public health framework, the continuous systematic monitoring of local pharmacy sales for antidiarrheal medications to detect an early waterborne outbreak is an example of what specific function? Think back to our radar metaphor. Answer. Surveillance, which falls into the broader function of identifying, measuring, and monitoring health needs. Review the functions of public health section.
And to leave you with a final provocative thought to mull over on your next shift. The text explicitly notes that determining the level of acceptable risk regarding environmental pollutants or viral exposure is ultimately a political and policy judgment, not a purely scientific calculation. If that is true, if health is negotiated, how should you, as a future medical or public health leader, prepare yourself to advocate effectively for your patients in the brutal halls of government legislatures, and not just in the quiet confines of the clinic?
Here are the details in this episode.
GPH 1. The scope and concerns of public health.
Byline.
From individual illness to collective well-being, understanding the architecture of population health. Episode description.
In this opening episode of the Public Health series, we explore the intellectual and moral foundations of public health as a discipline. This chapter defines what public health is, and crucially, what it is not.
Public health moves beyond the clinic. It shifts the focus from treating individual disease to preventing illness, prolonging life, and promoting health at the population level. It asks different questions. Not why did this patient develop disease, but why do some populations experience higher rates of disease than others?
We examine the historical evolution of public health, from sanitation reform and infectious disease control to the modern era of non-communicable disease, behavioral risk factors, and global health governance. The chapter introduces the core triad of public health functions: assessment, policy development, and assurance.
It also highlights the inherently interdisciplinary nature of public health. Epidemiology, biostatistics, sociology, economics, environmental science, political science, ethics, and law converge in a field that must operate within complex political systems and across sectors.
At its heart, public health is concerned with equity. It asks who is left behind and why.
This episode lays the conceptual foundation for everything that follows in Season 12. Before we examine methods, policies, or diseases, we must first understand the scope, the breadth, ambition, and ethical commitments of public health itself.
Key takeaways.
Public health focuses on populations, not individual clinical encounters.
Its core mission is prevention, health promotion, and prolongation of life.
It operates across disciplines and sectors, not solely within healthcare systems.
Health outcomes are shaped by social, economic, environmental, and political determinants.
Public health requires systems thinking and long-term strategic vision.
Equity is central. Reducing avoidable and unjust differences in health is a defining goal.
Public health action often requires balancing individual liberty with collective benefit.
Effective public health requires leadership, governance, and evidence-informed policy.